Bismillahirrahmanirrahim. Quote of the day: remember, Allah does not burden our soul more than it can bear. Today, I will present the critical appraisal with the help of a short checklist of one article, Global Mortality Associated with 33 Bacterial Pathogen in 2019, a systematic analysis for the Global Burden of Disease Study 2019 under kind supervision of Professor Dr. Saira Afzal. First, we discuss the abstract. Reducing the burden of death due to infection is an urgent global health priority. Previous studies have estimated the number of deaths associated with drug resistance infection and sepsis and found that infection remains a leading cause of death globally. This is the first study to present global comprehensive estimate of deaths associated with 33 bacterial pathogens across 11 major infectious syndrome. And methods: we estimated death associated with 33 bacterial genera or species across 11 infectious syndrome in 2019 using methods from the Global Burden of Disease, Injuries and Risk Factor Studies, GBD 2019. This study included 343 million individual record or isolates covering 11,361 study location year. We used 3 modeling steps to determine the number of deaths associated with each pathogen, death in which infection had a role, the fraction of death due to infection that are attributable to a given infectious syndrome, and the fraction of the death due to an infectious syndrome that are attributable to a given pathogen. Estimates were produced for all ages and for males and females across 204 countries and territories in 2019. 95% uncertainty intervals were calculated for final estimates of death and infection associated with the 33 bacterial pathogen following standard GBD methods by taking the 2.5th and 97.5th percentile across 1,000 posterior draws from each quantity of interest. And in the finding section, we estimated death associated with the 33 bacterial pathogen to compromise 13.6% of all global death and 56.2% of all species-related death in 2019. 5 leading pathogens are found after this study: Staphylococcus aureus, E. coli, Streptococcus pneumoniae, Klebsiella pneumoniae, and Pseudomonas aeruginosa were responsible for 54.9% of deaths among the investigated bacteria. The age standardized mortality rate associated with these bacterial pathogens was highest in the Sub-Sahara Africa super region with 230 deaths per 1 lakh population and lowest in higher income super region with 52.2 deaths per 10,000 population. Staph aureus was the leading bacterial cause of death in 135 countries and was also associated with the most death in individuals older than 15 years globally. Among children younger than 5 years, Strep pneumoniae was the pathogen associated with most death. In 2019, more than 6 million deaths occurred as a result of 3 bacterial infectious syndrome, with lower respiratory infection, bloodstream infection, each causing more than 2 million deaths, and peritoneal and intra-abdominal infection causing more than 1 million deaths. Interpretation: strategies to address the burden of bacterial infection include infection prevention, optimize use of antibiotic, improve capacity for microbiological analysis, vaccine development, improved and more pervasive use of available vaccine. These estimates can be used to help set priorities for vaccine need, demand, and development. So in the title and abstract, They indicate the study design. A systematic analysis for the global burden of study 2019 was mentioned both in title and the abstract. And abstract provide a balanced and informative summary of what was done and was found. Now discuss the introduction. Communicable diseases have long been highlighted as a global public health priority and are recognized as a leading cause of health loss globally. To date, no global burden estimate exists for many common bacterial pathogens, making establishment of public health priorities difficult. The few estimates that do exist are often constrained to a specific pathogen, infectious syndrome, or in the high-income countries. For example, global estimate of the burden of Streptococcus pneumoniae are available, but these estimates are mostly restricted to children younger than 5 years, 13 years, or as a cause of pneumonia or meningitis, and do not reflect the total burden across all population and all infectious syndrome. In this study, we present to our knowledge the first global estimate of death associated with 33 clinical significant bacterial pathogens, both susceptible and resistant to antimicrobials across 11 infectious syndrome in 2019. Background is given but not well explained. Rationale is clearly and well elaboratedly defined in the introduction section, and objective of this study are also clearly defined. Methods. In the method section, the input data that are used for this whole study are the multiple cause of death and vital registration data, hospital discharge data, linkage data sources, mortality surveillance in the child health and mortality prevention surveillance study, literature review of the microbial cause of meningitis, neonatal sepsis, lower respiratory infection, UTI, skin infection, peritonitis, bone and joint infection, and the laboratory-based passive surveillance data. These all are the data which are used for the input of this study. In the methodology section, they divide it into 3 parts: death, in which infection played a role. We develop a random effects logistic regression model to predict the fraction of death involving sepsis for each underlying cause of death, age, sex, and geographical location using method described previously. Use this cause fraction, we estimate the number of deaths for which the underlying cause was non-infectious and sepsis occurred. And in the infectious syndrome estimate, within our modeling framework, an infectious syndrome is the infection directly responsible for sepsis and serve as the bridge between the underlying cause of death and sepsis. We estimated 11 infectious syndrome. We then used syndrome and age-specific mixed effect logistic regression model using sex, healthcare access, and quality index. These are the scale which are used: sex, healthcare access, and quality index, and syndrome-specific bias, covariates, and a nested random effects on underlying cause to estimate the fraction of sepsis-related death that were caused by each infectious syndrome for each underlying cause of death, age, sex, and geographical location. And in the pathogen distribution section, they estimate the fatal pathogen distribution and calculate syndrome-specific and pathogen-specific case fatality rate using data that link pathogen-specific disease incidence to death and the meta-regression Bayesian regularized trimmed MRBRT tool. We estimated case fatality rate as a function of age, healthcare access, and quality index, and various bias covariates that were specific to the data for each infectious syndrome. We then use the pathogen-specific and syndrome-specific case fatality rate to produce a pathogen distribution of number of deaths estimated for each infectious syndrome by age and location. In this analysis, we do not report estimates for Mycobacterium tuberculosis because this specific pathogen is already a part of global strategies. And in the last section of methodology, they estimating mortality and year life losses. To estimate the number of deaths due to the pathogen of interest, we multiplied the number of deaths for each underlying cause, age, sex, and location by the fraction of death in which infection had a role, the fatal infectious syndrome fraction, and the pathogen fraction, and summarize across all underlying cause of death and infectious syndrome to estimate the number of deaths. Were the criteria used for deciding which studies to include in the review reported? Yes, the type of study is clearly mentioned. Systematic analysis for the global burden of disease, participant setting and population are clearly mentioned in the data input section of the methods. Intervention are clearly mentioned in the introduction section of the article, and the outcome of this study is they estimate the mortality and year life losses due to these 33 bacterial pathogens. Was the search for evidence reasonably comprehensive? Yes, there is no restriction based on language. There is no restriction on the publication status, and the relevant database which are used for the literature search of the article. We conduct literature search to obtain input data for the following components in the analysis: meningitis etiology, case fatality, maternal and neonatal sepsis etiology, low respiratory infection etiology, UTI etiology, skin infections etiology, intra-abdominal infection etiology, bone and joint infections etiology. Search strings including Boolean operators were used in a PubMed to systematically search for the causative microorganism for these infectious syndrome. Does the review cover an appropriate time period? Yes, the search period is comprehensive enough that relevant literature is unlikely to be omitted, and it is clearly mentioned in the title of the study, Global Burden of Disease Study 2019. Was bias in the selection of the article avoided? The answer of this question: list of included study are already discussed, and the exclusion criteria for literature review are used. Part 1 of the inclusion criteria: non-peer review papers or a publication or a case report. And in the part 2, they exclude case control study, intervention studies, and the study based entirely on modeling with no raw input data. Sampling occurred in a selected population. And in sample size lower than 50, studies that included just one pathogen, studies that reported combination of pathogen together without disaggregating by pathogen, studies based entirely on modeling with no raw input data, studies with a biased sampling framework. Only included studies are English, and search string included constraints on a 1 year. These are the exclusion criteria which are used for in this study, and I will take this screenshot from the supplementary material of this file in the appendix 1. Did the author use appropriate criteria to assess the quality and risk of bias in analyzing the studies that are included? Yes, the criteria used for assessing the quality risk of bias were reported, and a table or a summary of the assessment of each included study for each criteria was reported, and the material was given in the supplementary file in Appendix 1 section. Results. From an estimated 13.7 million infection-related deaths in 2019, there were 7.7 million deaths associated with the 33 bacterial pathogen across the 11 infectious syndrome estimated in this study. We estimated death associated within the 33 bacterial pathogen to comprise 13.6 of all global death and 56.2 of all sepsis-related death in 2019. 5 leading pathogens, Staph aureus, E. coli, Streptococcus pneumoniae, Klebsiella pneumoniae, and Pseudomonas aeruginosa were responsible for 54.9% of death among the investigated bacteria. The deadliest infectious syndrome and pathogen varied by location and age. The age standardized mortality rate associated with these bacterial pathogen was highest in Sub-Sahara Africa superregion with 230 deaths per 1 lakh population and lowest in the high-income superregion per 1,000 population. Staph aureus was the leading bacterial caused death in 135 countries and was also associated with most death in under 15 globally among children younger than 5 years. Strep pneumoniae was the pathogen which is associated, and in 2019, more than 6 million deaths occur as a result of 3 bacterial infectious syndrome, lower respiratory tract infection, bloodstream infection, and the 2 million deaths and the 1 million deaths are reported due to peritoneal and intra-abdominal infection. Were the characteristic and result of the included studies reliably reported? Yes, the table or summary of the characteristic of participants' intervention and outcome for the included study are given in the supplementary file in Appendix 1. Table or summary of the result of all included study given also in the supplementary file, and in this article they gave the result in the form of age standardized mortality rate of all bacterial pathogen, and the table of age standardized mortality rate are seen in this article. Are the method used by the review authors to analyze the finding of the included study clear, and including methods for calculating effect size if applicable? Different methods are used to analyze the finding described in the section of methods of this article. Did the review describe the extent of heterogeneity? Yes, the systematic analysis ensured that included studies were similar enough that it made sense to combine them, sensibly divide the included study into a homogeneous group, and the systematic analysis discussed to that extent there were important differences in the result of the included study, and the meta-analysis and chi-square test was not done, and the age standardized mortality rate and year life losses was calculated related to the every bacterial pathogen. There was a qualitative justification for this systematic analysis was done. Were the findings of the relevant study combined or not combined appropriately relative to the primary question, the review address, and the available data? It presents result of all sensitivity analysis conduct to assess the robustness of synthesized result, and it's also present in the supplementary file in the appendix section 1. Did the review examine the extent to which specific factors might explain difference in the result of the included study? Yes, there is a different factor explained which affect the result section. Discussion. To our knowledge, this is the first study to provide global estimate on mortality and year life losses for a wide range of bacterial genera and species across 11 major infectious syndrome. By estimating mortality and year life losses for a broad range of pathogen and infectious syndrome, we have produced a global account of bacteria for which the burden was previously unknown and perhaps underappreciated. The 33 bacterial Agents investigated as a part of this study comprise a significant cause of health loss globally, and strategies to address the substantial burden cover a wide range of intervention. Many barriers to assessing these effective antimicrobials have been described. First, healthcare seeking behavior are impeded by high out-of-pocket costs, driven by deficiencies, government funding for health, and unaffordable drug prices in low-middle income countries. Unwarranted antibiotic use caused by poor education of healthcare provider, unstable supply chain, and poor quality control can result in the desired antibiotic being unavailable or the dissemination of substandard or counterfeit antimicrobials to the consumer. Three syndrome are responsible for more than 75% of the estimated 7.7 million bacteria-related deaths that occur in 2019. And this is lower respiratory infection, bloodstream, peritoneal, and intra-abdominal infection would rank as the 3rd, 7th, and 13th leading cause of death globally. We should also acknowledge Mycobacterium tuberculosis, which was not included in our analysis. One reason we did not do additional estimate for this important because this important pathogen is the global burden estimate provided by Global GBD 2019 and WHO are quite concordant and well established against this pathogen. Insufficient microbiological capacity has substantial effects on both population health estimate and the clinical care of individual patients. Urgent need exists to build microbiology laboratory network and develop innovative surveillance strategies. Our study in the discussion, they also discuss about the limitation. Our study has several limitations, many of which are the result of data sparsity. Input data for each modeling step has incomplete geographical coverage and is of varying quality for many low middle income countries, and we did not have data for 61 countries or territories for all three of our modeling steps. Does the review report evidence appropriately? The review report evidence clearly in discussion section and also report the biases, provide a journal interpretation of the result in the context of other evidence, discuss the limitation of the evidence included in the review, and discuss the implication of the result for practice, policy, and future research. In summary of this article, our analysis show that bacterial infection are a clinically significant cause of health loss globally. 5 pathogens were each involved in more than 50,000 deaths in 2019. Staph aureus, E. coli, Strep pneumoniae, Klebsiella pneumoniae, and Pseudomonas aeruginosa. 3 infectious syndrome, each responsible for more than 1 million deaths in 2019, comprised more than 75% of death due to bacterial infection. And the other information which provided the entirety of the global burden of disease, injury, and risk factor study has been registered and proved through the University of Washington Institutional Review Board. Financial support can be found in the acknowledgement section. Bill and Melinda Gates Foundation, Wellcome Trust, and Department of Health and Social Care use UK aid funding managed by the Fleming Fund. Declaration of interest from different authors will also given at the end of this article. The data collection form, citation for all data used, analytical code, and the result will be available on the Global Health Data Exchange upon publication. This is the YouTube link of this critical appraisal.
Very nice. Thank you very much. Our Dr. Naila, this is a very good presentation. The most important part is that you have checked all the important things that are present in SURE checklist. And whenever we are doing any critical appraisal of a systematic review, we have to go through the standard checklist. So we would stop here and we would again click the same link in order to have the discussion and feedback on this session. And you can stop recording, please. Allah Hafiz.